So we're talking about, with neurocognitive, is mainly taking off the main focus. But the big deal is trying to understand when you have neurocognitive disorders, exactly what is going on. Okay. Depression is not a normal part of getting old. You have a client that's elderly and telling you, I just don't feel like I want to go on anymore. I don't really see much point in life at all, especially if it's an elderly man. Should you take him seriously and consider suicide?
Yes.
Elderly men are the most lethal when it comes to a suicide attempt. So depression is not normal. Melancholy, some sadness here and there. It gets kind of sad when, you know, a lot of people that are your age are, obvious things. White males, highest risk for a suicide, and if they're going to do it, they're usually the most effective. Usually a gun, and they will. It's not going to be a failed attempt. We need to understand the difference between, understand what delirium is. Delirium, we will go over it a lot more, but it's acute onset. It is not dementia. It is not Alzheimer's. It is something is going on medically, and you need to recognize that. So we'll cover it more. Dementia is slower onset. And we'll talk a little bit about alcohol use, self-medicating it in the elderly. And so just like I said, you have an 80-year-old client who has difficulty walking because of shortness of breath, secondary to COPD, and said every day is a struggle when you get old. No one cares about old people. So as a nurse, you need to recognize, are they talking about their COPD to you? No. So which answer do you think would be the best? B. Yeah, B, exploring. We want to dig a little deeper and find out if they'll talk to us about what's going on. A is just treating it as a medical response. You know, they just got a medical problem and you're just going to do some teaching. B is appropriate. You're reframing what they said. Sounds like you're having a difficult time, and then you're exploring. Tell me about it. Then C is kind of being a cheerleader, okay? And that's not what they need at this point. And D, you're trying to objectively look at it, you know. Well, yeah, you ought to be happy, you know. You can still get around. That's, they don't need to be objectified there and rationalizing it. That may probably make them feel worse, guilty for feeling bad. So a few definitions. We've talked about cognition already, especially when we talked about cognitive therapy. But it encompasses a lot of things. Comprehension, judgment, memory, reasoning, you know, our ability to reason between what we want to do and what we should do, you know, making those good decisions. But then, like I said, now delirium is acute, usually reversible alteration in consciousness, okay? It's usually accompanied by disturbances in thinking, memory, attention, and their perception of what's going on, and it has multiple causes. Can anybody think of something that might cause delirium? Lack of sleep. What else? UTI in an elderly. Yep, there's a lot of things, but those are some of the most common.
Isn't levodopa usage? Like, I read somewhere that they can cause delirium and there's
Some
an
medications,
antipsychotic that
definitely.
you have to give them.
How often do you think nurses fail to recognize dementia?
A lot.
Percentage of the time?
A lot.
Some research has shown almost 75%.
That's not good.
Can that be life-threatening? Yeah, because what can the UTI lead to? Sepsis and death. Yeah, so if you're just assuming I've got this little old lady and she's just a little confused, and you don't do what? What do you need to do next?
Assess all of it.
Assess. Okay, now dementia is progressive, and it's usually irreversible. Big differences there. Deterioration in their cognitive and intellectual functions and memory. And it's different from dementia in that it usually does not affect their level of consciousness, where delirium can affect their level of consciousness. Okay, they can be in a stupor with a mild neurocognitive disorder. It's when someone has mild dementia and they're somewhere between normal functioning and you can just tell they're having some memory issues, mild. Major is to where the neurocognitive disorder impairs their ability to take care of themselves and they're no longer able to be independent. So, do we have normal changes that take place neurocognitively as we get older without it? Yeah, we do, and that's just a fact of life. Slower response times and loss of short-term memory. Where did I put my keys? That happens to me every day. Having trouble remembering names or something like that. Just some short-term loss. Maybe a little slower response time. You've been driving all your life and you find you just don't respond as well and you don't like to get on the interstate. Those are normal. Okay, so what we'll be talking about today are not normal. And it's important to remember that confusion is not a normal part of aging. You know, where did I leave my keys as opposed to, I need keys? What are you asking? A confusion. That's not a normal part.
What about just completely forgetting what you were about to say?
Depends on, well, like we said at the beginning of mental health, frequency, intensity, and duration. Did it just happen while you're totally stressed out and you had a lot going on and it's a couple of months? I mean, some of the things that go on, you know, we got to watch, you know, divorces, nursing school, losing a job, losing, you know, things like that can cause you to struggle with memory or staying organized and things, and it might not last just a day. You know, if you, a lot of times when you're at work, when I was nurse manager, and a nurse would come in and be like, I'm sorry, I missed work the other day. I had to call in. My dog died or something, and I was just so upset I couldn't do it. You know, I couldn't come to work. That's temporary. But when they come to you and tell you, I'm going through a really, really bad divorce and stuff's coming up in the next couple of weeks and all, that person is going to struggle for a while. And they're like, I promise I'll be better. You know, I'll be all right next week. And we're usually like, no, you probably won't be. And, you know, there may be, you know, they may need a little something to get through that hard time. Trying to think, that just comes to mind the most. But, so you look at frequency, duration, and intensity. After all that's over, are you able to get back on track? Do you remember better? Are you more organized with your thoughts and all that sort of stuff? That was just related to something going on. What we're talking about today with dementia and Alzheimer's, which are the main ones on your syllabus, they are not going to get better. We're not teaching these patients new skill sets. By the time they learn it, the progressive nature of disease, that doesn't help them anymore. So, okay, so we did the mental status exam the other day in the lab, and you saw how it looks at several areas, and those are those cognitive areas. With neurocognitive disorders, you'll see disruptions in a lot of these areas, but to diagnose like, just say they have dementia, you would need to make sure they have problems with their memory. They can have a lot of stuff going on, but kind of the red flag is memory issues. And so the one that comes to mind that could temporarily affect you is the delirium. When we talk about dementia and Alzheimer's, it's progressive and it's not temporary, it keeps on. So we talked about defense mechanisms in Unit 1. And with neurocognitive disorders, you'll see defense mechanisms as people start to experience these problems. This is talking about the defense mechanism in the patient. Confabulation. To the family or friends, it may just look like lying. They're not telling you the truth. They're making up stories to fill gaps in what is missing for them. Denial. Your daddy says I'm getting dementia, but I don't think so. I think it's just normal. Denial. I did not forget that. Getting mad, denial. Let's see. And I've got some. Your ATI book is really good as we're going over this, but it's not your do-all, end-all. But it is good for studying this. And if you look on page 89 in your ATI, some of these defense mechanisms are defined right there. Nice, succinct little definitions. Like perseveration, they deny answering your questions by repeating phrases. Just kind of subconscious denial, defense mechanisms. And also in your textbook, page 436, table 23-1, is a good table looking at the different, comparing aging versus Alzheimer's. Alzheimer's is 60% of all dementia too, so when
Can you repeat that table again?
page, table 23-1 should be aging versus Alzheimer's. So let's talk a little bit about delirium. Okay, so it's caused by a disturbance of the brain, by a medical disorder or a substance. So you could have drug-induced delirium for sure, or a medical disorder. It's considered a syndrome and not a disease. It's common in hospitalized patients, especially older adults. And if you fix the underlying problem, which that's your goal, well, you want to fix the delirium, but you fix the delirium by fixing the underlying goal, it should almost always clear up. Okay, so a lot of times in the mental health unit, the medical mental health unit that has a lot of the dementia clients and all, you'll almost always have a patient or two that came in through the ER and disoriented with delirium, and they end up getting sent to the mental health unit. They get some fluids, get their sodium level straightened out, get the UTI cleared up, or just the dehydration, and then they're fine. They didn't need to be on the mental health unit, they had delirium. Some of the causes: alcoholism, a brain tumor, chemical intoxication, depression, several things here that you would need to be looking at. And on page 431 in your textbook, it talks about a workup that you could expect to do on somebody with delirium, trying to rule everything out. You can tell what kind of, you're going to be drawing electrolyte levels, you're going to be drawing an alcohol level, you could be doing a CT to look at their brain. The workup could be very extensive to try to rule it out. Some of the first things, what do you think that first lab work you're going to look
UA.
at?
UA.
Yes, UA and electrolytes.
CMP.
And look at those. do an assessment as to their hydration level, how dehydrated are they? Kind of the key here is rapid onset. The family brings mom in and she's woo, and they're like, is this, you know, and you're asking them, is she always this way? No, she's never like this. First time she's ever this way. And they ask you, well, is this the onset of Alzheimer's? And you're like, no, Alzheimer's comes on slow. This happened acutely just today, right? And they're like, yeah. So rapid onset. Symptoms vary sharply in a short period of time. Their judgment is impaired. They're not making good decisions. Their affect, we talked about affect, facial expression, how you, tone of voice, how you come across, fluctuates. Memory of recent events is affected. They will be disoriented. Where are you at? Like, you know, the questions you were asking last week in the lab. Do you know where you are? Do you know what day it is and time? They will be disoriented. Person in place. Difficulty sleeping. Incoherent speech. Just all sorts of signs and symptoms. Sorry, y'all. This is the patient that'll be wandering the hall, agitated, kind of difficult to get back in their room, maybe, especially in the hospital we're talking about here. It's important to remember it may be the first and only indicator of an illness, so you can't blow it off. For example, if they're toxic on a drug, this may be the first and only symptom you would see is this delirium. Pneumonia, an MI, so you need to assess. You need to follow up when you see this behavior. Children may be susceptible to this more so, especially when they're in that kind of, in the febrile state. We already know when children have high fevers, they get neurologic and vomit, they can have seizures. So it goes to make sense that they may also have delirium. Of people over 65, admitted for general medical conditions, it's estimated about 10% of them will end up with delirium. Oh, an admission, I'm sorry, and 20 to 25% while they're in the hospital. So high numbers. They're going to have perceptual disturbances. They can't tell what they're seeing is real or not, and they'll hallucinate. Kind of like what I was talking about my grandpa seeing the little kids playing in the room at all. Kids weren't there at all. And they could have wild dreams. Their thinking process is disturbed and disorganized. They can't solve simple problems. They have problems recalling, retaining, and bringing to mind a memory. And their wakefulness pattern is often disturbed. They'll often sleep, some during the day and then be up wandering a good bit at night. So their sleep and wake pattern is reversed. What's your big concern with these people? Falling. So risk for injury, deficient fluid volume, fear. They may be scared. Somebody scared can be really hard to take care of, so you need to reassure them, stay with them. Don't try to confuse them further. goal, like we said, is to get them back to their normal neurologic functioning, neurocognitive functioning, without getting hurt in the meantime. And you want them reoriented. Do you know where you're at now? Oh yeah, I know where I'm at. I'm in the hospital. What day is it? They may be a little off, but they're reorienting the person in place. There is a really good box on page 435 in your textbook going over this assessment of a patient with delirium. So you want to look over that. It's what I just went over on the slides. The big thing, like I said earlier, you just don't want to assume they have dementia. You've got to make sure you're assessing thoroughly and you understand and try to find out what's going on with them medically. It's the most frequent problem with elderly in the hospital. This is the person you want to try to keep them quiet. Make sure they're eating and drinking in this state. You know, try to adequate nutrition. They may need supplements. They may get some psychotropic meds just to handle the agitation. You know, when you talk, you know, your core measures that you have in the hospital for med-surg patients, you know, you've heard us talk about core measures. Like if someone is having surgery, one of the core measures is they have to have their antibiotics a certain amount of time before surgery, and they have to have them discontinued, you know, all these guidelines. Mental health and long-term care also have core measures. And one of the big core measures in long-term care is the percentage of clients that are on antipsychotics. So when we talk about using a psychotropic, it could be an antipsychotic, something like a Haldol or something to calm them down and help with the agitation. But they monitor real closely how many people are in long-term care on an antipsychotic, because it used to be just about everybody. Because you put them on that really high-powered antipsychotic med, then you don't get a whole lot of roaming and agitation because everybody is sedated, okay? So you use these meds with somebody, especially with delirium, because your focus on is trying to get them better. You don't just jump to some antipsychotic med just to get them to be quiet and get back in their room and not fall. You have to figure out what's going on. So just keep in mind when we say some psychotropic meds with them, we're just trying to temporarily handle these symptoms of dementia. And they may have psychosis going on, just totally out of touch, and behavioral issues. So they will be trying to treat those while they get them fixed with whatever the underlying problem is. Okay, so that's delirium. Now we're going to talk about dementia. Alzheimer's is the most frequent one. It can be, dementia can either be mild or major, like we talked about earlier. It can just be something that you notice is going on, or it can be to the point where they can no longer take care of themselves. It's a syndrome of the brain function, and like we said, it's characterized by gradual progression of the symptoms. And it, global impairment of their intellect as it progresses. No change in consciousness. Their level of consciousness should not change. That's different than delirium, right? So, key point there. Impaired judgment and inability to make reasonable decisions. Majority are irreversible. Alzheimer's certainly is. And they're disoriented to person, place, and time. Okay, so how do we diagnose it? These are the 5 A's. Amnesia, they must have memory loss. apraxia. Their motor system will be intact. You know, they don't have a mobility issue, but they have trouble doing things. So it's a neurologic problem with doing things, not a motor impairment. Agnosia, they don't recognize normal objects. What is this? I don't know what that is. And it's a telephone. Aphasia, ability to receptive and expressive, and then abstraction problems. They have a deterioration of their executive functioning. Did you make your doctor's appointment for next week to follow up? No, I just couldn't get that done. And, you know, executive functioning, planning, organizing your day, planning meals around your house, your normal executive functioning that we should all have. That starts to break down. Characteristics, we hit on these briefly before. Confabulation, which can cause some frustration with family, comes across as just telling fibs, but it's making up stories to fill gaps. Repeating a term, the perseveration, repeating it over and over again. Mood swings. Marked anxiety or depression. Personality changes. They could have psychotic or behavioral disturbances. Sundown syndrome, up at night, wandering around, confused at night. And sleep pattern reversal. Up all day, up all night, sleep all day. The characteristics are on page 438 in your book. And you know, as you're looking at all of this, the key with Alzheimer's is they will be worked up for everything to make sure you're not just missing a medical condition, especially a younger person. So page 439 is a good summary of the workup of some of the stuff you may have on someone who is starting to have these issues. To rule out, is it a mobility issue? Is it a tumor? Is it a metabolic problem? Or are there mood changes to do with a metabolic issue? You just want to make sure you have ruled out everything. It was first described with Alzheimer's now. The dementia that is Alzheimer's was first described in the 1900s by Dr. Alzheimer's, who treated a patient with these signs and symptoms that we just went over. In 1906, the patient died, and during the autopsy of the brain, that is when they were able to see the changes in the brain during autopsy. It had atrophy, so hardened up, gotten smaller, and just little knots of the neuron, and the neurons were like knotted masses that they saw. Neurofibrillary tangles. I just like to think of it as, you know, your neurons have all those little tendrils and stuff tangled up, unable to function appropriately. I noticed on autopsy. And so between the findings that they saw on this client's autopsy and then the symptoms and all that they saw before she died is when came up with this labeling at Alzheimer's. And usually the course of Alzheimer's is 9 to 10 years. It will end in death. So stage 1, on page 438 in your book. Mild and early stage, mainly the forgetting stuff. And this is the point where they kind of look like everybody else, but they still have to go through the studies. Normal forgetfulness, nothing serious as far as memory problems yet. Stage 2 is still very mild, and the changes have not become apparent to the family or the providers. Forgetfulness continued. That's where I sit and I'm self-diagnosing myself. Then stage 3 is mild. This is when you start to see things other than just the forgetfulness. So when they start to have some cognitive problems. Losing things. Can't remember where I put my jewelry. Went on a trip, put my jewelry somewhere safe. It's a year later, I still have no idea where I put it. That's not okay. Can't plan. Things that they used to could put together and organize and plan and put together can't do. This starts to become noticeable to their family and to close friends. They can't hold the attention long. What were you saying? I'm sorry. Difficulty with words and names. And they start to have problems in social settings. And you can see how this is different than just normal aging. Normal aging, we said you would have slower, maybe some response times, and some short-term memory losses. But you shouldn't be having trouble just planning your day. You shouldn't be having trouble planning a meal. You should still be able to go to whatever your social functions are and do and function normally, not have them causing you problems, agitation.
And do you lose your long-term memory?
This starts
With
to
this?
come along. Starts to unravel kind of from the beginning up.
I have a question. The difficulty with social work, the agitation, all that. Nowadays with the new diagnosis of ADD and stuff, can it be considered a form of adult ADD too? Like that type of?
Well, I don't think they're not the same thing, and that's why.
What could it be misconstrued as?
Yeah, and it kind of goes back to that ruling out everything, you know, and making sure you're not seeing something that could be something like an adult ADD and thinking it's Alzheimer's. Whole big difference. So it's where you have to rule it out, and you make sure they have all these other things going on, and not just the ADD. And also, this is a change in someone that's elderly. And occasionally you see it in younger people, but this is a change. Usually by the time you're an elderly adult, you would have recognized your signs of ADD and things, and you would ask people, is this new? Or, yeah, well, I just never realized what it was when I was younger, but yeah, I had these issues when I was younger. But if it was Alzheimer's, it would be, no, I've never really had this. This has just been within the past 6 months or a year. That's a definitive difference. Now, in your book, before I forget, let's see, page, I want to look it up. Table 2322 is a really good table that compares depression, dementia, and delirium. Okay. Table 23.2. I didn't write down but we teach classes on this in the hospital. This is a challenge, you know, making sure you're identifying what's going on with the client. But so I like this box as you're studying, just to kind of make sure you're on track. And I'll try to find it here in a sec. Well, moving along. We'll go back and find it on a break.
So if you have a mild stage, like stage 2 or stage 3, and then you get a UTI and have delirium and all that, can that progress the stages and it won't go
No,
back?
that's a really good question. She's asking, you know, if you're in the early stages of dementia or Alzheimer's, and you end up, say, with the UTI and you get delirium from it, would it exacerbate it or keep you from getting back? It's real hard to pick apart what you're seeing, because it'll be on top of the dementia. Depending on how long it goes along, you should get back to your normal stage of dementia. Does that make sense? Because it shouldn't last so long that meanwhile your dementia is just progressing and progressing and progressing. But it will make it really hard to tell what is going on because one is on top of the other. That's why you go back and look at those key differences like level of consciousness. And your goal is to get back to the way they were before. If you weren't taking care of them before, you're really going to be dependent on friends or family to tell you, are
What
we
was their
seeing,
norms?
is this the way it was before the delirium set in? So if you're caring for them and you had a good assessment and then they got the delirium, then you know what you're shooting for to get back to. You're certainly, if they already had the early stages of Alzheimer's, you're not going to get them back. You know, they're going to go back to that stage. Okay, so stage 4 is moderate, and this is where you get personality changes. She just doesn't act like herself, you know, and I've seen that in a family member. This person that used to be really easygoing and stuff, their personality changed. That's certainly not a normal part of aging. Obvious memory loss. Everybody can tell. The doctor who only sees them every 6 months can tell they have memory loss. Limited knowledge and memory of recent happenings and personal history. So they have a hard time telling you what happened just recently, the things that went on with them. And their executive functioning is impaired. This is the person that's gonna need help with housework. This is the person that is going to need to make sure someone is making sure they're eating. They have difficulty doing math. We certainly shouldn't have that problem. As you get older, you should still retain your knowledge. But if they're having trouble doing math, they can become moody and withdrawn at this stage. Then moderate to severe. At this point, you will start to see disorientation to time and place, which is a little different. Inability to recall important details. Do you remember when you got married? Stage 6, only one more stage. This is just everything is getting worse. Kind of not aware of what's going on around them. Incontinence, they can be violent. Worsening memory. Agraphia, they may not be able to read and write. Hyperorality, they put everything in their mouth. And this, they have trouble recognizing normal objects. Stage 7 is very severe. They usually end up dying from choking or an infection. They begin to not be able to move, then they end up in stupor, coma, and die. You have to have assistance with infant.
Now, these 7 stages, these are all just for Alzheimer's related dementia?
Mm-hmm.
Or all forms of dementia?
Mm-hmm. Alzheimer's. Now, the diagnosis, like we said, was by exclusion, which means you've ruled everything else out. You don't draw a blood test and say, oh, look, we got the results back, it's Alzheimer's. It's by exclusion. And like we said on that mental status exam, to start with, they have to have at least 2 deficits, but one of them has to be memory. You're making sure it's not med toxicity, or you've got 2 meds that are interacting and causing these symptoms. They don't have something going on in their brain like a tumor, thyroid disease. Could be a lot of other things causing these symptoms. So you rule out the Alzheimer's you make sure it's Alzheimer's by ruling out everything else. Again, your nursing diagnosis, safety, they're at risk for injury, difficulty communicating. And you know, everything we've talked about kind of so far is we're trying to maybe teach them how to rethink what's going on, like cognitive therapy, or we're teaching them some new behaviors, some behavioral therapy, or we're giving some medication to help get rid of the signs and symptoms or minimize the signs and symptoms. Your care plan with these clients are going to be handling what's going on with them now. How are we going to manage this confusion? How are we going to take care of them with their memory problems? And you're not going to fix it. Does that make sense? It's these care plans are just handling the stage they're at now, keeping them safe, and doing the best you can do for the stage they're at now. You know, I'm not going to take a patient that we've ruled everything else out with Alzheimer's and with their family and say, all right, we're going to sit down and come up with a family plan to kind of take care of mom for the next 2 weeks until she can kind of get back on her feet and be independent again. That's the wrong direction for this family and this client. We need to say, you know, how is mom doing today, and how are we going to manage this? Does somebody need to come stay with her at night? Do we need to have a community group maybe that she can help her with meals, or a sitter? And then after we manage it for a while, then as things progressively change, we will get back together and readdress it. Okay? And one of the big issues with this is caregiver role strain. This is a strain on family or the caregiver, whomever they may be. So a lot of your nursing care will be with the family and the caregiver. If you work in the hospital, you may have taken care of clients that come in just for respite care. And that's to give the family some time to do something. So you can admit this client to the hospital for a few days, and the family can have just what it is, a respite. They may need a quick vacation, some time away. They may just need some days to do everything else around their house. Your ATI book, also on page 90, is a good comparison of delirium and neurocognitive disorders. And so as you're studying, that one's a really good one to go over. So treatment. On page 91 in ATI are the cholinesterase inhibitor meds, and this is a new class for us that we haven't studied so far. But these are the first line meds to treat Alzheimer's. And so when we say treat it, if they're treating the signs and symptoms, are they going to fix it? Are these meds going to? No. They're going to slow down the progression. Now, what is similar to this group of meds, your Ariceps and all the ones you hear a lot of ads on TV, they're dealing with neurotransmitters. So, just a different neurotransmitters. What were some of the neurotransmitters we already talked about?
Serotonin,
dopamine. And we're
dopamine.
gonna add acetylcholine to the group. And just like with when you give an SSRI, you're trying to keep that circulating serotonin level up. That's the same as what you're doing with this group of meds. You're trying to keep that circulating available level of acetylcholine available. And that helps neurons transmit messages, more to do with not the feel goods. You know, we talked about serotonin is kind of the happy kitten feel. Acetylcholine is more with what, you know, thought processes. And so by keeping the enzyme cholinesterase inhibited, it breaks down less acetylcholine. Now, the big thing with these meds, if you look at your adverse effects, there's some GI issues, nausea, vomiting, diarrhea. Is this the group you want dehydrated?
No.
No. So if you're prescribing this, you've really got to make sure, if you're instructing a patient that's got this prescription, you know, if you're having diarrhea and all, you gotta do what? Talk to your doctor, keep your fluids up. We don't want you dehydrated because this could make you more confused, could lead to the delirium. And then it also has a risk for bradycardia and syncope, this falls. Okay, so all that good nursing education about getting up slowly, not turning around quickly, you want to keep down the risk of falls. This group of meds should be given with caution to people who have asthma or like COPD because of respiratory problems with the acetylcholine. So if they have COPD, it would be given with caution. There's also a risk for bleeding if they're taking like NSAIDs or aspirin. So it's real important to assess what type of over-the-counter things they take. And teach them about the signs and symptoms of a GI bleed. Now another class, if you see the Namenda there, memantine, it's in a group by itself. It's used with moderate to severe dementia or Alzheimer's. And it works on the calcium that comes in and out of the cells. It can be given at the same time with the acetylcholinesterase inhibitor. It helps with it kind of works to help slow down the death of the brain cells. Okay, so you may see it given with, say, the Nezapil.
They can be given together?
Mm-hmm. And these are, and it's on page 92 in ATI. And then if you look there, they can also be given an antipsychotic or an SSRI or some type of other psychotropic med, but it's pretty controversial as to the benefits. Do the benefits to this client outweigh the side effects that come along with these other groups of meds? So it just depends on the client's symptoms and is it worth giving it to them. And these are some of the atypical antipsychotics. And you may see those given, but they're going to be given sparingly because they do have a lot of side effects. And you know this person is not psychotic, they're having psychosis show up from an organic brain problem. So you don't want to make them more confused and have all these side effects to try to fix something that's just progressively going to get worse. They may be given a benzodiazepine, like Ativan, if they're agitated. And you give something like Ativan, because it's got a short half-life, gets out of their system quick, and hopefully they'll calm down and it will work on the agitation. Buspar that we went over the other day also is used to help reduce anxiety in these clients. Sometimes some mood stabilizers. Don't need to get real in the weeds on it for Alzheimer's. And then you want to look up, make sure Depakote and Neurontin sometimes help with the anger and aggression. So good many meds there, but a lot of them we've already covered. Just want to make sure you go over that new group, especially the acetylcholinesterase inhibitors. And so the memory impairment, like we mentioned earlier in Alzheimer's, the memory kind of unravels backwards. The first activities learned as a child are some of the first ones to be forgotten. So as they're losing their ability to remember how to do things, it may be some of the most basic things they learn. So we're going to go ahead and take a break until a quarter after, and then we'll come and get started back up at that point. Finish this up.